Hello, let's do dermatology. So, basic principles, skin layers. Let's get sunburned. So, the stratum corneum, and then the stratum lucidum, that's the clear one, and it's only present in thick skin. And then the stratum granulosum. Granulosum is the one that has the keratinocytes that start keratinization and cells form links. Okay, and then spinosum. Spinosum is where squamous cells are present, and they start keratin synthesis, and it's the thickest layer. And then stratum basal. This is the one that has the melanocytes. Another name for it is germinativum. Okay, now these are just the names of the lesions. Yeah. So a macule is a flat lesion. A macule is a flat lesion that's more than 1 centimeter. A patch is more than 1 centimeter. A papule is elevated. A plaque is a papule that's more than 1 centimeter. A vesicle is fluid filled. A bulla is a vesicle that's more than 1 centimeter. A pustule contains pus. A wheal is transient. It could be a papular plaque, so it's an elevated lesion, but it's transient. A scale is flaking, and a crest is a dried exudate from the vesicle. Now, there are some microscopic terms. Dyskeratosis is abnormal premature keratinization in squamous cell carcinoma. Hyperkeratosis is increased thickness of the stratum corneum. Parakeratosis is retention of nuclei in stratum corneum. And both of these happen in psoriasis and hypergranulosis, increased thickness of the stratum granulosum. That was the one that's right underneath the lucidum, I believe. Yeah. And then spongiosis is epidermal accumulation of edematous fluid in the intracellular spaces. Acantholysis is separation of the cells. Acanthosis is epidermal hyperplasia, so increased spinosum. So yeah. And then there are some skin types. Fitzpatrick skin types. We have 1, 2, 3, 4, 5, and 6. And the more the number increases, the more the melanin and tanning ability increases. So skin type 1 is pale, with blonde red hair and blue-green eyes. These people always burn; they never tan. 2, they burn easily and they tan poorly. 3, first of all they burn and then they tan. 4, they tan, and then 5 and 6, they rarely burn, they always tan. Now let's look at keloid scars. Keloid scars are most common in the sternum, shoulder, neck, face, extensor surface of the limb and trunk. They're less likely if the incisions are made along relaxed skin tension lines. They're treated with intralesional steroids, and excision is sometimes required, even though I think it increases it or something. Kubner's phenomenon is skin lesions that appear at the site of injury. This is seen as psoriasis, vitiligo, warts, lichen planus and sclerosis, and molluscum contagiosum. This is interesting because in molluscum, when you scratch at the papule and it releases the fluids that were inside, the fluids then infect nearby skin, and this is how it increases. Immunofluorescence. Now, this is just a compilation of the most important ones in the immunological skin diseases. So we have bullous pemphigoid, lupus erythematosus, linear IgA disease, dermatitis herpetiformis, and scleroderma. Now, in bullous pemphigoid, there is linear deposits of IgG at the dermo-epidermal junction. Okay. So it's linear. And then there's also another linear one, but it's IgA, linear IgA disease. This is linear IgA deposits at the dermo-epidermal junction. Okay. Now, granular IgG deposits is lupus. This happens along the basement membrane, lupus band test. And then dermatitis herpetiformis, this is associated with celiac, so it's IgA deposition in the epidermis. And then IgM deposition is scleroderma. So again, let me try to repeat this from memory. So if we have linear deposition, it's either bullous pemphigoid if it's IgG, or linear IgA disease if it's IgA. If we have granular deposition at the epidermal junction. No, not at the derma epidermal junction. At the basement membrane, IgG, it's lupus. IgA, um, in the epidermis, it's dermatitis herpetiformis, and then scleroderma is IgM along the basement membrane. Now let's look at the erythemas. Now this one actually came in the previous exam, and I got it wrong because there's a lot of erythemas. So I don't know. I feel like I want to Google this and just see what Google's going to do with it, because I would love a picture of all of these next to each other. Okay, let's do one by one. So let's start with erythema nodosum. This is an elevated lesion. It's tender. It's a subcutaneous nodule on the shin, and it's associated with many things. Some of them are sarcoidosis, pregnancy, oral contraceptive pills, sarcoidosis, pregnancy, oral contraceptive pills. But not just that, but also a lot of drugs. Okay, so these are the drugs. I remember them by PSPS. So penicillin, sulfonamide, contraceptives pill, and omeprazole. How was that PS? I don't know. Yeah, I'm done. Okay. Penicillin, sulfonamide, contraceptive, omeprazole, and then lymphoma, and then sarcoidosis, IBD, and Behçet, and then streptococci, TB, and brucellosis, and then pregnancy. So all of these are associate causes of erythema nodosum. And if the person has erythema nodosum, you must do a chest X-ray, because it helps exclude two important causes, which is sarcoidosis and tuberculosis. Okay, let's go back. The next erythema is erythema multiforme. So erythema multiforme is a target lesion. This is how it looks like. It's a target lesion. The most common cause is herpes simplex. Really? Yeah, herpes simplex. Also drug reaction. Also mycoplasma hepatitis. So let's write this down. So the most common one, but also mycoplasma hepatitis, drug reaction, and the drugs that causes are sulfonamide. So like erythema nodosum as well. Penicillin was also a cause of erythema nodosum, and barbiturates. Okay, now erythema migrans. This is why does it look like a target lesion? It just looks so similar. Erythema migrans versus erythema multiforme. Okay, so multiforme is a target-like lesion. Migrans is a bull's-eye appearance. I don't know what a bull's-eye appearance is. It's like a circle and then another circle in between. Yeah, it still looks pretty similar to me. So, erythema migrans is the distinctive bull's-eye rash of Lyme disease. Erythema multiforme is a reaction to HSV or meds. Okay. This is caused by Lyme disease. The treatment is doxycycline. Now, erythema marginatum is pink evanescent rings in the trunks and limbs associated with rheumatic fever. So let's also add that. So if we add that, then we have erythema marginatum is a fleeting pink ring-like rash on the trunk limbs, usually from rheumatic fever, and appears with heat. So erythema marginatum is a macule with a central clearing. It spares the phase that happens in the body. Okay. By the way, tinea also causes this ring-like lesion. Tinea. but it would be itchy and it would have slightly raised borders. Okay, so that's the difference. Now let's look at the rest. So we have erythema ab. I don't know how to pronounce that. Let's see. Pronunciation. Erythema ab igni. Okay, igni. So erythema ab igni. It's a reticulated hyperpigmentation caused by infrared exposure. So exposure to heat. There was a patient who was a hypothyroid patient, and also another patient who used a lot of heating pads for pain. So these are the people who will be affected by this. It has a net-like or marbled appearance. Yeah, that's how it looks like. Articulated. Net-like. Marbled appearance. Okay, erythema gyratum repens. This is the wood grain pattern. So, wow. That looks insane. Subhanallah. This is a paraneoplastic lesion of what cancer? I believe it was lung cancer. What was that? Lung cancer? Yeah. So it's a wood grain pattern and a figurate erythema. So it has a particular shape. Okay. Then erythema infectiosum. This is slapped cheek disease. Yeah, slapped cheek. And then erythema induratum. This is a painful ulcerating nodules like paniculitis that happens on the posterior aspect of the calves, like the back of the legs, and it happens with TB. So these are the erythemas. I think the most common ones are the ones at the top. So nodosum, multiform, migrans, and marginatum. And it's very easy to confuse between them. So multiform, this is the target lesion of a herpes and drug reaction. Migrans, I will remember this by a migrant, someone who migrates, like me when I hike from somewhere to another. I don't know if that even makes sense, but that's how I'm going to remember it. So this happens when you go on a hike and you get a tick bite and you get Lyme disease. Marginatum, I will remember this. Rheumatic disease, marginatum. That makes no sense, but yeah. Okay, now let's go to the skin infection. So impetigo, common in children, direct contact with discharge, staph or strep. There would be golden crystal lesions around the mouth. It's very contagious. How to treat? That's the most important thing, because once you recognize this, the next question would be how do you treat it? So depends. Is it a limited localized disease or is it an extensive disease? If it's a limited localized disease, you use a topical cream. Hydrogen peroxide 1% is the first line, and then topical antibiotics. What is that? What is this drug? Topical antibiotics. Oh, really? Okay. If it's extensive, we give oral antibiotic, and then we exclude the patient from school until all lesions are crusted. Now, erythrasma is basically an asymptomatic flat, scaly rash found in the groin or axilla. It's caused by overgrowth of the diphtheroid Corynebacterium minutissimum. It will have coral red fluorescence, and the treatment is with topical miconazole or antibacterial, and if it's extensive, we do oral erythromycin. So again, another disease treated by topical antibacterial. This time it's miconazole. For impetigo, it was fusidic acid or retapamulin or whatever. Yeah. The Woods Light thing is nice because it would be nice to compile them actually. Maybe I can do like a very quick derma compilation. Even though I don't have a lot of time. Yeah. I don't know if I want to do this. Okay, never mind. There's no time to do it. Myogenic granuloma. eruptive hemangioma. Okay, so what is this? It has an unknown cause, may be caused by trauma, pregnancy, more common in women and young adults. Causes trauma or pregnancy, and it's more in women and young adults. The most common sites are the head and neck, upper trunk and hands. It's initially small red-brown spot that rapidly progresses to be a raised red-brown lesion, spherical in shape, that may bleed or ulcerate. This is how it looks like. Very interesting. The lesions are associated with pregnancy. It resolves spontaneously postpartum. If they persist, we would do curettage, cauterization, cryotherapy, excision. So, treatment. Resolve spontaneously if pregnancy. Otherwise, you do curettage and cautery, cryotherapy, or excision. So this is what a pyogenic granuloma is. Now for molluscum contagiosum, it's self-limiting, but you can do cryotherapy or simple trauma. Eczema herpeticum is a severe infection that's happens in children who have atopic eczema and then they get infected with herpes simplex. The lesions are rapidly progressing, painful, intensely itching, monomorphic. This is an important one because I picked polymorphic in a question. It's monomorphic, papulovesicular, punched out, and the treatment would be IV acyclovir. There's an important differential diagnosis, which is Coxsackie. So it's the same one, but it would be caused by Coxsackie virus, and it would not respond to acyclovir. So that's the important difference between eczema herpeticum, and if it's caused by herpes simplex, you give acyclovir. If it's caused by Coxsackie, it will not respond. And then there's another also differential, which is dermatitis herpetiformis. So this is an autoimmune IgA-mediated reaction. It will be chronic, relapsing, grouped vesicles and papules. But eczema herpeticum is a dermatologic emergency. It would have monomorphic punched out erosions, papulovesicular erosions. Yeah. Okay. What is a papulovesicular erosion? No, it's a papulovesicular rash with punched out erosions. That's what I meant. Now let's go to tinea. Tinea is a tinea corporis and capitis. Capitis in the scalp. The most common one is Trichophyton tonsurans, but there's also Microsporum canis from a dog. If the patient does not have a pet, please don't pick this because it will not be the answer. The most common one is tonsurans. Trichophyton. Now, corporis, which happens in the trunk, legs or arms, would be caused by rubrum or verrucosum from cattle. Now, capitis, scarring alopecia, mainly in children. The most common one is tonsurans. That's the most common cause. It could be complicated by a chorion. A chorion is a raised pustular boggy mass. Now, how to diagnose? Direct microscopy. There would be hyphae and spores, and then we can culture, and then Wood's light. So Wood's light, Microsporum would be green fluorescence, Trichophyton would be no fluorescence, and then there was something else that causes a red fluorescence, which is the erythrasma causing one, this one. So, erythrasma cord red fluorescence, Microsporum is green, Trichophyton has no fluorescence. So most of the tinnias would have no fluorescence actually. Now, how to treat microsporum is treated with terbinafine, and trichophyton is treated with griseofulvine. Microsporum is treated with terbinafine, and trichophyton is treated with griseofulvine. Now, just remember that it's the opposite. So, trichophyton would want to make you think about terbinafine. No, it's not. It's griseofulvine. And green fluorescence would want to make you about griseofulvine. No. Everything is just mixed up. It would have been amazing if it was trichophyton, terbinafine. No, let's just don't confuse yourself, okay? Microsporum, green, terbinafine, trichophyton, no fluorescence, griseofulvine. Okay, so it's sneaky. Tinea corporis is in the body. You would treat this with oral, not topical. Fluconazole pedis. Fungal nail infection treatment of choice is always oral terbinafine. Incognito is an atypical presentation. These would happen in patients who are immunosuppressed. If an undifferentiated cutaneous lesion worsened after empiric treatment with steroids, this suggests a dermatophyte, because dermatophyte infection would worsen after giving steroids, okay? Now, there's another fungal infection called tinea versicolor or pityriasis versicolor. This is a superficial cutaneous fungal infection caused by malassezia furfur and globosa. It's precipitated by immunosuppression, malnutrition, Cushing, but it also occurs in healthy individuals. It affects the trunks and it causes hypopigmented patches with scaling. Treatment is topical ketoconazole shampoo, and if there's failure, we give oral itraconazole. Now, fungal nail infections, I think we did this already. It's oral terbinafine treatment. Let me see if there's anything else to know about this. I feel like I need to compile the treatments at the end. If it's limited, topical ammo. What is amorolfine? Okay. More extensive. Due to a dermatophyte. Well, isn't it already caused by dermatophytes? Extensive, then it would be according to the cause. If it's dermatophyte, we give oral terbinafine. If it's candida, you give pulsed weekly oral itraconazole. That's how you treat. Okay, so it was oversimplified. Now it's better. So tinea pedis, if it's limited, you give topical amorolfine. If it's extensive, then you have to do nail scrapings, and you can give terbinafine if it's dermatophyte, or itraconazole if it's candida. Now, scabies, intense pruritus. Something important about scabies is that it's a delayed type 4 hypersensitivity reaction. So, if the itching persists, that does not mean that you need to repeat the treatment, because this is just the hypersensitivity reaction, and it's not caused by reinfestation or reinfection. Okay. Diagnosis would be scabies ink test. Treatment first line would be permethrin 5% and then malathion 0.5%. Now for eczema, it's just an inflammatory or not inflammatory. It's I just want to know what the term eczema refers to because that's important. It's a non-contagious dermatitis accompanied by pruritus, erythema, and papule. It's a non-specific term. Okay. Well, there's nothing much I can say here, except that I have to learn the treatment. So it's treated by some anti-allergic treatment. So antihistamines or H1 inhibitors, H1 blockers are used in the treatment of allergic rhinitis and urticaria. We can give sedating, like chlorpheniramine, or non-sedating. And if we're going to give non-sedating, the least sedating is loratadine. So that's the best one. However, and cetirizine causes more drowsiness than loratadine. So loratadine is the best. Montelukast can be added. So if the patient needs 2 antihistamines, we can add Montelukast to help. Now for topical steroids, the rule is to use the weakest steroid cream which controls the patient's symptoms. So the mildest is hydrocortisone, 0.5 to 2.5%. For moderate, it's beta-methazone, 0.025. Keep in mind that beta-methazone 0.1 is potent, but 0.025 is moderate. Now, clobetazone is also moderate. So, not sol. So, zone is moderate. Humavate. But clobetasol is very potent, which is also called dermovate. Now, fluticasone is potent. So, this is how you have to know the different steroid creams. The dose, there's a fingertip rule. So, each fingertip is 0.5. And the fingertip, one fingertip unit is sufficient to treat a skin area about twice of the flat of an adult hand. So if we're going to treat, for example, an entire leg and foot, we would need 8 fingertips. An entire arm and hand, we would need 4 fingertips. Face and neck, we would need 2.5 fingertips. Back and buttocks would need 7. Front of the chest and abdomen would need 7. A foot all over would need 2. And the hand and fingers front and back would need 1 fingertip. So that's the rule. So this is the quantity that should be prescribed for an adult for a single daily application for 2 weeks. So let's say an adult would need to treat their face and neck. We said the face and neck needs 2.5 fingertip units. So that's each fingertip unit is 0.5 gram. So that's 2.5 times 0.5. So that's 1.25 grams. So if it's needed once per day, we have to multiply that by 14 days. So the patient will need to be prescribed 15 to 30 grams for the face and neck twice a day for 2 weeks. Okay, once a day, for 2 weeks. Okay. Now, contact dermatitis, it could be non-allergic, just irritant, or it could be allergic. So it's a type 4 hypersensitivity reaction like scabies. The classic picture of dermatitis would be a flexural rash with poorly defined areas of erythema, dry skin, and lichenification. That's the classic picture. Now there's another type of dermatitis called seborrheic dermatitis. It has a biphasic distribution. It affects infants and adults. It's a chronic inflammatory reaction to the proliferation of Malassezia furfur. Remember, first of all, Malassezia is normal skin flora, and the second is that it caused Pityriasis versicolor. Now again here, it's causing seborrheic dermatitis. It would cause eczematous lesions on sebum-rich areas. It may cause blepharitis and blah blah blah. It's associated with HIV and Parkinson's, and the treatment would be topical ketoconazole in the scalp. The first line would be ketoconazole shampoo, um, or like zinc pyrithione containing and tar containing preparations, selenium sulfide, or topical corticosteroids. This is for scalp seborrheic dermatitis. For face and body, we would use a topical ketoconazole or topical steroids for short periods. Now, Pompholix is a dyshydrotic eczema, affects the hand and feet. So, hand is chiro, feet is pedo. It's precipitated by humidity and high temperature, and it causes small blisters that burst and can lead to dry, cracked skin. They're very, very, very itchy. They have a burning sensation. Treatment is cool compresses, emollients, and topical steroids. Now, keratoderma blenuragica is differential diagnosis of Pompholix. It's associated with reactive arthritis, and it's a pustular, waxy, brown rash on the soles of the feet. But it's not red, nor is it itchy. Unlike Pompholix, Pompholix is very, very itchy, and it's on the palms and soles. Okay. Now, erythema multiforme. I feel like this was covered. Erythema multiforme is the one that is associated with herpes simplex and drugs. There's target lesions on the back of the hands and feet. Upper limbs more than lower limbs. Pruritus is mild. The causes of herpes simplex virus is the most common cause, and ORF is also a cause. Also some drugs, a lot of drugs. Nevirapine, sulfonamides, carbamazepine, allopurinol, nonsteroidals. So target lesion is the characteristic picture of it. Now, Stevens-Johnson syndrome is a severe systemic reaction affecting the skin and mucosa. It's a delayed hypersensitivity reaction that involves T cells, and it's almost always caused by a drug reaction. So we have penicillin, sulfonamides, lamotrigine, carbamazepine, and phenytoin, so anti-epileptics, allopurinol, nonsteroidals, and oral contraceptive pills. All of these are causes of Stevens-Johnson syndrome. A marker of carbamazepine-induced SJS is the HLA allele B1502 in Han Chinese populations. It's a maculopapular rash with target lesions and positive Nikolsky sign and mucosal involvement. Toxic epidermal necrolysis is basically SJS that's affecting more than 30% of the body. There would be eosinophilia on blood test. A significant problem of toxic epidermal necrolysis is fluid loss, because there's a lot of fluid lost in the vesicles or bulli, and if it's extensive, then you're losing a lot of fluid, which makes your blood more viscous and may cause VTE. Treatment is supportive care in the ICU. We can also give IVIG plus or minus cyclosporin, cyclophosphamide, and plasmapheresis. Okay, now granuloma annulare is basically small, firm, smooth papular lesions Wait, I feel like I remember something. Pyogenic granuloma. This is not the same as pyoderma gangrenosum, even though it sounds so similar. But it's not. So granuloma annulare is hyperpigmented, depressed. It's associated with diabetes. Okay. Lichen sclerosus, first-line treatment is high-potency topical corticosteroid. Okay. Why is this even here? Shouldn't this be with lichen the other lichens. Anyways, pyoderma gangrenosum is a rare, non-infectious inflammatory disorder. It's associated with neutrophilic dermatosis, so there's dense infiltration of neutrophils. It would be seen in ulcerative colitis and Crohn's, also rheumatologic diseases, hematologic diseases, and also autoimmune like GPA and primary biliary cirrhosis. It's very painful, mostly in the lower legs. Something very important about pyoderma gangrenosum is pathergy. So when it's injured, the lesion softens and healing is affected. So we need to avoid debridement of the wound. It starts as a sudden small pustule that becomes a large, deep necrotic ulcer with biolaceous undermined edges. We would do a pathergy test and biopsy, and we would find neutrophilic infiltration. The treatment would be topical super potent steroids or tacrolimus. Tacrolimus is even better. This is for mild disease. If it's severe or moderate, we would give oral steroids. If it's refractory, we would give cyclosporin or infliximab or adalimumab. And any surgery should be postponed. Now, pityriasis lichenoides is pityriasis lichenoides et varioliformis acuta, PLEVA, is the acute form of the disease, and PLC is the chronic form. It would be reddish papules that can become vesicles or pustules, may develop into hemorrhagic crusts, sometimes leaving scars, which can be itchy or burning. I'm sorry, what? This is a rare disease, so I don't want to spend a long time here. Okay, how to treat this? Topical tacrolimus, topical steroids, and anti-inflammatory antibiotics. I don't know, I feel like I need a mind map because this is getting too much, so I'm going to pause, create my mind map, and then come back.